Good evening, students. I hope everybody are busy in pre-Diwali celebrations. Okay. Hi, hello everybody. Good evening. So we'll be having a very crisp session, respiratory medicine INICET Predictor series. So we'll be discussing what an examiner is asking these days. So shall we start, students? The first question. There was a 50-year-old male in OPD. He is being evaluated for daytime sleepiness and memory loss. His BMI is given. So whenever there is somebody with daytime sleepiness and increased BMI, the first possibility that we all think is obstructive sleep apnea. And most of you say this is obstructive sleep apnea. But this is INICET. It will not be as simple as this. They have also taken an ABG. ABG is showing high PaCO2. Whenever there is obstructive sleep apnea with hypercapnia, it means patient respiratory effort is not sufficient. This entity is not a simple obstructive sleep apnea. It is obesity hypoventilation syndrome. Come on, students, what is the other name for obesity hypoventilation syndrome? Anybody from the audience, what is the other name for obesity hypoventilation syndrome? It is called as Pickwickian. This can also be asked, Pickwickian syndrome. The best answer here is OHS. So in a clinical scenario, when you have obstructive sleep apnea with hypercapnia, you need to rule out obesity hypoventilation syndrome. Here the patient is so much obese that his fat in the chest, fat in the abdomen is not allowing his respiratory effort to happen. Then why it is not central sleep apnea? Here the problem is only when the patient sleep. Here patient is awake. So this is not sleeping problem. Problem is even in awake. Respiratory effort is not happening. Narcolepsy, nothing to do with respiratory effort. Patient suddenly sleeps. It is excess sleeping. Such question can be asked. Everything will be very similar to OSA, but there will be hypercapnia. Make sure you rule out obesity hypoventilation syndrome. Then the following spirometry is suggestive of. Now they have mentioned that this is patient normal and this is the patient's FEC and FEV1. So if you notice here at the end of first second, whatever you get is FEV1. So this is normal. Okay, normal is orange. So I'll draw like this. This is normal. So normally it is somewhere in between 3.5 and 4. But this patient, this green is patient. It is only 2. So FEV1 is somewhere 2 liters. Whereas FEC, if you notice, both are nearly the same. So this FEC, if you notice, if you plot, this is FEC. This is FEC. It is somewhere 4 liters. 4 liters. So now if you notice 2 by 4, if it is 0.5. It is 0.5. If you want in percentage, it is 50%. So whenever FEV1 by FEC ratio is less than 70%, it is obstructive. So out of all this, which is obstructive, your answer should be bronchiectasis. So they have mentioned that this green is patient. At the end of first second, this is FEV1. How much is FEV1? 2 liters. How much is FEC ultimately? So he has blown out this much. Ultimately, it is 4 liters. So maximum that you blow out is 4 liters. At the end of first second, 2 liters. Normally, it should be the ratio should be 70 to 80%. Normal is 70 to 80%. It is low. So this is obstructive. Always expect one question from spirometry. Whenever they give you any spirometry, first see the ratio. If the ratio is low, what is it called as ratio low? Come on, answer. It is obstructive. If the ratio is normal or increased, still it can be normal lung or restrictive lung. Anybody from the audience, how will you differentiate a normal lung and a small lung called as restrictive lung? It is a lung size. How will you say lung size in conventional spirometry? Patient's FEC. So FEC will be less than 80% predicted. Then, if it is obstructive, we need to do bronchodilator reversibility testing. Now, somebody tell me, which is bronchodilator reversibility positive? Is it asthma or COPD? Asthma or COPD? Your answer should be asthma. Asthma is bronchodilator reversible. Bronchodilator not reversible is COPD. Generally, bronchiectasis is variable. Bronchiectasis in few situations it can be positive and it can also be bronchodilator responsive negative. Then if it is restrictive, depending upon where the restriction is happening. If it is happening directly in the lung, it is called as intrinsic restrictive lung diseases. All that which will cause shrinking of the lungs, fibrosis, ILD, occupational lung disease. Can you tell me extrinsic restrictive lung diseases? Few example. Your lung is healthy, but something outside your lung is not allowing your lung to expand properly. That extrinsic restrictive lung diseases, we have kyphoscoliosis, neuromuscular disorders. This is what is called as spirometry algorithm. First see the ratio. If ratio is low, your answer should be obstructive. No second thought. And if it is obstructive, look for bronchodilator reversibility. If bronchodilator reversibility is positive, it is asthma. Then if the ratio is normal or increased, see FEC. FEC is low, it means small lung, then it can be restrictive. Then try to solve this question. pH and ABG anion gap also definitely one question. pH is 7.34, PaCO2 is 60, PO2 is given bicarbonate. If you have followed my routine classes, I always say write down the parameters first and draw arrow marks. pH, PaCO2 and bicarbonate. These three parameters are sufficient for assessment. This is decreased when compared to normal, whereas PaCO2 increased. Normal is 40. Here it increased to 60. Bicarb, normal is 26. Here it increased to 34. Anywhere decrease in pH is acidosis. Acidosis. Got it? And what is primary? We have a rule. If change in pH with respect to parameters, opposite direction, it is respiratory. If you notice here, change in pH with respect to parameters, it is in opposite direction. So it is primary respiratory. Primary respiratory. Then how to calculate compensation? Now if they don't give history, whether I should consider it as acute or chronic, just to see the pH. If the pH is very nearer to normal, means the compensation is a chronic phenomena. So in the same case, if the pH was somewhere below 7.3, most probably it can be acute. Still your kidneys are not ready, compensation has not brought it to near normal. Because it is coming to near normal, maybe body's compensatory processes are working. So usually kidney requires some time. If the compensatory process has to work, it must be generally a chronic disorder. As far as respiratory acidosis with renal compensation is considered. So here CO2 has increased from 40 to 60 by 20. To call it as compensation, there is a rule. For 10 increase in CO2, bicarbonate should increase by 4. For 20 it will be 8. So if your body has given adequate compensation, bicarbonate should have been at 34. Here it is at 34. So it is respiratory acidosis with compensatory metabolic alkalosis, or in very simple words, it is written as compensated respiratory acidosis. Very simple words, it is written as compensated respiratory acidosis. First, let me teach you how to identify the disorder. Like I told you previously, if at all it is a primary respiratory acidosis, the main problem is increased CO2. And whenever CO2 increases, as a compensation, bicarbonate will also increase. In respiratory alkalosis, the main problem is decreased CO2. Respiratory alkalosis means CO2 washout. For any decrease in CO2, what will happen? Bicarbonate will also decrease. So point to know here, in respiratory, change in pH with respect to parameters, they are in opposite direction. Whereas in metabolic, to call it as metabolic acidosis, bicarbonate should decrease, that is primary. And for metabolic acidosis, compensation is respiratory alkalosis. To call it as metabolic alkalosis, bicarbonate should increase. For metabolic alkalosis, compensation is respiratory acidosis. There is a very simple rule called as ROME. If it is primary respiratory, the change will be in opposite direction. Like I have shown you, change in pH with respect to parameters, opposite. And for metabolic, it will be in same direction. You can notice here, change in pH with respect to parameters, it is in same direction. This is one important rule to say which is primary. Then we know that this is the usual formula that we apply for compensation. In acute, for every 10 mm Hg in CO2, bicarb increases only by 1. In chronic, it increases by 4. This is the formula that I have applied in the previous question. Then high anion gap is found. Generally, for anion gap to increase, what should happen? Bicarb should decrease and acid anion should increase. Generally, high anion gap, if it increases, it is usually metabolic acidosis. So high anion gap usually happens due to addition of acid. It happens due to addition of acid. So whenever acid is added, that H plus is buffered by bicarbonate. So bicarbonate decreases, so it will be metabolic acidosis. Acid anion will add up, increasing the anion gap. But for your exam, they'll ask you, what are the causes of high anion gap metabolic acidosis, normal anion gap metabolic acidosis? Kindly know this rule. To call it as high anion gap, the disease should be addition of some acid to your body. That acid might be either keto acid. That acid added can be keto acid, lactic acid, acid formed in your body not going out, as in renal failure. Generally in renal failure, many acids are formed in your body, and if they are not going out adequately, then this can be responsible for a high anion gap metabolic acidosis. And any substance that can form acid in your body, you should be knowing, any alcohol or aldehyde when added to your body will form acid. Methanol, formic acid, ethylene glycol, oxalic acid, or any drug that is acid, it is aspirin. Then all other conditions causing metabolic acidosis will generally be normal anion gap. Normal anion gap is not due to addition of acid, it is due to loss of bicarbonate. Pancreatic fistula, ureterosigmoidostomy, diarrhea, carbonic anhydrase inhibitor use, aldosterone deficiency, renal tubular acidosis. Very important, if you find that acid is being added to your body, blindly the answer should be high anion gap metabolic acidosis. A very common question, radiology based question. Somebody is having productive sputum and cough This is the CT chest features. So metformin overdose, it comes under lactic acidosis vidia. Metformin will cause lactic acidosis. Got it? All those, metformin will cause lactic acidosis. Now see here, this is your trachea, and can you see abnormal dilated airways? Abnormal dilated bronchi. Anywhere abnormal dilated bronchi is nothing but cystic bronchiectasis. Now in cystic fibrosis also there will be cystic bronchiectasis, but the pathology with the given information is cystic bronchiectasis. If at all they have mentioned it is a child, and in if cystic bronchiectasis is not given, next option will be cystic fibrosis. In cystic fibrosis there can be bronchiectasis, but here age is very important. It is not very young, and the pathology here is cystic bronchiectasis. I don't know what vidia. Lactic acidosis is also causing high anion gap metabolic acidosis, and metformin causes lactic acidosis. So obviously it has to be high anion gap only. Okay. Yes. Cystic bronchiectasis. So the best answer is cystic bronchiectasis. The pathology is bronchiectasis. Just by seeing CT, you cannot call it a cystic fibrosis. You say there is bronchiectasis, then for bronchiectasis there are 50 causes. In that, cystic fibrosis is one answer. Which is correct regarding ILD? Again, ILD is a hot topic in respiratory medicine. Which is correct regarding ILD? What should be your answer? Honeycombing pattern is not common. Is common pattern in NSIP? It is wrong. Actually, this is multiple correct options. Respiratory bronchiolitis has strong association with smoking. Yes. Idiopathic pulmonary fibrosis has poor response to steroids. Yes. So you can also expect multiple correct answers. Respiratory bronchiolitis is associated with smoking. It is true statement. Idiopathic pulmonary fibrosis has poor response to steroids. Yes. So here it has poor prognosis. And if at all the examiner wants to ask one question from ILD, it will be definitely from this table. How are both different? Somebody tell me, in whom UIP occurs? Young or elderly? It occurs in elderly. Male or female? Male. Smokers or non-smokers? Smokers. And usually long duration of symptoms. Can anybody tell me the classical biopsy finding, radiology finding? Come on, type. What biopsy finding confirms it as UIP? Fibroblastic foci. This is the pathognomic finding. Then what radiological finding will make you suspect it is UIP? It is honeycombing. Most important radiological finding apart from traction bronchiectasis is honeycombing. And what is the prognosis? Bad. Death is due to respiratory failure. And treatment, generally pirfenidone, nintedanib, but they are not reversing the disease. Best treatment will be lung transplant. Then NSIP. Now tell me, students, is it young or elderly or middle age? So NSIP is generally middle age. Here it is more female predominant, and subacute symptoms, fine crepitations, and you don't find significant fibroblastic foci. And what is the classical radiological picture of NSIP? Let me see how far you know. Radiological picture, it is not honeycombing, it is ground glass opacity. Because it is only mild haziness, good prognosis with steroid. Now whatever good happens with ground glass opacity, happens with girls. See, God is also very partial. Whatever good happens in females. Whatever bad happens in males. So good ground glass girls. It is non-specific interstitial pneumonia. Whereas whatever worst happens, being elderly is bad, being male is these days very bad in society, being a smoker is bad, having fibroblastic foci is bad, having honeycombing is bad, and this is a poor prognosis. So you have a movie called as Bad Boys, you have band called as Bad Boys. So nothing like that for girls. So whatever bad happens in UIP. Whatever good happens in NSIP. Then what is this question? Again, this is examiner's favorite. A 56-year-old female admitted with severe onset of right-sided pleuritic chest pain, breathlessness, oxygen saturations are given. Recent D-dimer is showing positive results. And ECG, sinus tachycardia, and CT pulmonary angio is showing pulmonary embolus. Based on the severity, is it massive, submassive, or minimal? Here, the patient's BP is low, shock. So this is called as massive pulmonary embolism. So in massive pulmonary embolism, initial, you have to stabilize the patient and you have to give low molecular weight apparent. But they're asking most appropriate ultimately will be thrombolysis. Again, they will give you a scenario and you have to decide, are you dealing with massive, or you dealing with minimal or submassive? For this algorithm, massive is also called as high risk case. Patient will be having shock and right ventricular dysfunction. Whereas submassive, normal BP, but some amount of RV dysfunction. Minimal, BP normal RV function. Maybe a small thrombus only, students. So how do you manage here? Initially, stabilization, anticoagulation, but best treatment is thrombolysis. Submassive, main treatment anticoagulation. In very rare scenarios, you may need to give thrombolysis. But if it is a small thrombi, only anticoagulation will be sufficient. So keep this in mind. In massive, main treatment is thrombolysis. In submassive, main treatment is anticoagulation. Then, this was a 67-year-old presenting with 2-year history of gradually progressing shortness of breath. There is pleural effusion. And in the pleural effusion, it is white. Whenever I say milky white pleural effusion, what are the differential diagnosis? It can be a high lipid pleural effusion. Now tell me, what are the causes of high lipid pleural effusion? It can be, approach should be like this: chylothorax or pseudo-chylothorax. In chylothorax, what is the disease defining feature? Pleural effusion, triglycerides more than 110 mg/. Pleural effusion, cholesterol more than 200 mg/. Now you have done pleural fluid analysis, protein LDH are high, mostly this should be exudate, but triglyceride level is not elevated, cholesterol level is elevated. So the cholesterol level, because it is elevated, this is pseudochylothorax. By chance, if the triglyceride was elevated, then it is chylothorax. It is due to injury to thoracic duct. Milky white fluid, chylothorax or pseudochylothorax. Because chylothorax needs triglycerides. Triglycerides are not elevated more than 110, but cholesterol is elevated. So the best answer will be pseudochylothorax here. This is the approach algorithm by seeing the lights criteria. If you find it is transudate, life is very easy. Only systemic cause. Is it heart disease? Is it kidney disease? Is it liver disease? If it is exudate, things will become very hard. Just like dealing with your ex, you need to explain so many things. You need to see whether it is malignant cytology. Is it any infective? Is it any TB? Again, TB markers, ADA will be more interferon gamma. Is it low glucose pleural effusion? Can you tell me the causes of low glucose pleural effusion? Empyema, malignancy, rheumatoid arthritis. In rheumatoid arthritis, very low glucose pleural effusion can also be seen, previously asked. High amylase, you have to evaluate. Is it pancreatitis, esophageal rupture, malignancy? High lipid, is it pseudochylothorax or chylothorax? This is in a nutshell. If they give you any pleural fluid analysis, see whether it is transudate or exudate. Transudate, only systemic causes, heart disease, kidney disease, liver disease. Exudate, is it malignant, is it infective, is it TB, is it low glucose, high amylase, high lipid. Accordingly, you have to come to a diagnosis. Then, a 30-year-old presented with features of acute pancreatitis. Few days later, he developed dyspnea. Chest X-ray is shown. What is the respiratory failure? First tell me, what did this patient develop? Whenever they mention there is pancreatitis, there is acute shortness of breath and bilateral pulmonary infiltrates. Maybe there will be also hypoxemia because this much involvement is there. If you see this in combination, one suspicion, ARDS. Again, ARDS is an examiner's favorite topic. If it is ARDS, the respiratory failure is type 1. How does pancreatitis cause ARDS? Whenever the pancreas are damaged, so many inflammatory enzymes spill into circulation, and these enzymes can reach your lung, damage your lung, and result in ARDS. ARDS is a type 1 respiratory failure, and they'll ask you what are the features of ARDS. For this, we have a diagnostic criteria. Acute shortness of breath within 1 week, chest X-ray showing bilateral diffuse pulmonary infiltrates. The pulmonary edema is non-cardiogenic and PaO2 by FiO2 ratio can be less than 300 mmHg. PaO2 by FiO2 ratio can be less than 300 mmHg. If you find this in combination, your suspicion should be ARDS. And what is the main treatment of ARDS? Mechanical ventilation. And in that low tidal volume mechanical ventilation, the magical number is 6 ml per kg body weight. And other options, we have PEEP, ECMO and prone ventilation. So when they ask you a question about ARDS, either they'll ask you the diagnosis. How do you say this is ARDS? And in treatment, the most important ventilator setting is low tidal volume mechanical ventilation. This is very important. Multiple times, if there is ARDS, either the diagnostic dilemma, how do you call it as ARDS, or on ventilator, what is the important setting, they are going to ask you. Then coming to, which of the following is a known consequence of asbestos exposure? The same increased risk of mesothelioma as cigarette use. Which of the following? Now see here, when the patient with asbestos is smoking, the chances of mesothelioma is not correlating with smoking. Smoking and asbestos actually synergistic for lung cancer. Kindly know this, mesothelioma is not lung cancer, it is pleural cancer. For mesothelioma, only risk factor is asbestos there, it is not smoking. So this is not the right answer. An increased incidence of both adenocarcinoma and small cell carcinoma of the lung. No. Asbestos is peculiarly associated with adenocarcinoma. An obstructive pattern, asbestos causes fibrosis. Because of fibrosis, there will be restrictive pattern. So if you leave all this, initially in asbestos, there is a pleural effusion, and in the initial stages, these pleural effusions are not malignant. First it will be benign, then there will be malignancy. First there will be benign pleural effusion, then this is malignant. Whenever examiner wants to ask one question from occupational lung diseases, asbestosis is a hot topic, and this table they'll ask you. Point to know asbestosis, the important features. There will be pleural plaques, pleural effusion. Here it is lower zone fibrosis. Malignancy most common is adeno. Most specific is mesothelioma, and there is another radiological feature called as round atelectasis. In silicosis, more of upper zone nodules, progressive massive fibrosis, lung cancer, and this is important. Silicosis is associated with tuberculosis. Alveolar macrophages damage or getting damaged by silica, more chance of TB. Bilateral hilar lymph node enlargement with eggshell calcification. Then co-workers pneumoconiosis, more of upper zone lesions, and it can cause complicated co-workers pneumoconiosis where there will be merging of upper zone lesions. And very important, there is something called as Kaplan's syndrome. This is combination of rheumatoid arthritis and pneumoconiosis. If at all examiner wants to ask one question from occupational lung disease, this table is very important. So I hope in the last 30 minutes, we have seen 10 predictor topics which can be asked in your exam. Before I conclude, I would like to give a list of topics. In symptomatology, approach to hemoptysis. In spirometry, what happens in emphysema? It means obstruction. And graphs, they might ask you fixed obstruction. Respiratory failure, types might be asked. And always hot topic is ARDS, pulmonary hypertension, pulmonary embolism treatment, various types of pneumonia. COVID, they can ask you drugs. Pneumothorax, usually tension pneumothorax is asked. Bronchiectasis clinical presentation. ABPA, they might ask you serum IgE, asthma, and central bronchiectasis, and this is very important. ILD, UIP, NSIP. In occupational lung diseases, asbestosis, and in sleep, very important, obesity, hypoventilation syndrome. And in lung cancer, they might ask you regarding the differentiation of adeno, small and squamous. ABG, most important is anion gap and basic interpretation. And tuberculosis, you can see the TB module. There we have discussed various definitions and treatment. So, yes, COVID, INICET 2023, they have asked a question. So we have in your class notes, I have given in a very crisp manner. You can go through it. They might ask you. So just that half an hour lecture and that 3 or 4 pages of notes will be sufficient. So with this, we will conclude. Don't worry, students. You all have worked very hard. Next few days, continue with consistency. All the very best and happy Diwali, students.